Good evening, and welcome to the 55th edition of the MENASO Education Academy Cerebrovascular Grand Round webinar in collaboration with the Sheikh Khalifa Stroke Institute. Last year, our webinar series engaged a global audience of over 9,000 participants. Building on that success, we're excited to present this year's session in collaboration with leading international societies, delivering cutting-edge research and insightful discussions aimed at advancing cerebrovascular disease. I would like to take this time and introduce and welcome my co-moderator for this session, Dr. Elizabeth Zink. And I did not introduce myself. I'm sorry about that. I'm Dr. Brenda Johnson from Johns Hopkins. I'm an acute neurovascular nurse practitioner, and I am associate professor at Johns Hopkins and assistant director of the Comprehensive Stroke Center at Johns Hopkins Hospital. Dr. Zink?
Hello, thank you, Dr. Johnson, and it's my pleasure to be here. I'm a clinical nurse specialist in the neurocritical care unit at Johns Hopkins and a member of the Sheikh Khalifa Stroke Institute, and it's my pleasure to be here with you today. Today, we will explore the complexities of cerebrovascular medicine with Lisa Klein first, discussing nursing care and stroke units, best practices, and the role of multidisciplinary teamwork. And then we will have another colleague of mine, Zena Corey, will talk about nurses as stroke advocates and educators building leadership skills. And finally, we'll have another colleague, Maha Aliawad, will present the role of nurses in stroke prevention and risk reduction. These are highly relevant topics, and I'm sure you'll find them both insightful and informative. The question and answer session will be after the last lecture, but please feel free to put comments in the chat and utilize the Q&A section. And so with that, I will introduce Ms. Lisa Klein. She is a certified adult gerontology clinical nurse specialist on two 32-bed acute inpatient and intermediate care medical surgical neurosciences units at the Johns Hopkins Hospital. Lisa received her Bachelor's of Science in Nursing in 2005 and Master's in Nursing in 2014 from Johns Hopkins University. And she's been certified in neuroscience nursing since 2009, a clinical nurse specialist since 2015. Over the past 18 years, she has championed efforts to increase patient mobility, decrease patient falls, and improve patient outcomes by leading evidence-based practice projects, mentoring staff, enhancing nursing education, and advancing quality improvement initiatives. Lisa has published as primary author and co-author on articles focusing on promoting mobility in the inpatient hospital settings and implementation of stroke centers. And so with that, I will give it to Lisa Klein.
Thank you so much for that introduction. I'm going to go ahead and share my screen. Okay. And I'm so happy to be here this evening to go over the nursing care on stroke units, going over some best practices we use and how we work as a interdisciplinary, multidisciplinary team to get to better outcomes for our patients. On arrival to the stroke unit, this is a very busy time. And what we've done to try to standardize our care is we have standardized order sets and we have standardized practices. So we get them settled into bed. We're going to put them on cardiac monitor and get a 12-lead EKG to see if they have atrial fibrillation on arrival. We're going to do a neurological assessment to get that baseline assessment for future assessments. We're going to put our patients' SCDs on their legs to prevent a DVT. We're going to go ahead and get a blood sugar, making sure that they are not hypoglycemic and treating if they are hyperglycemic. We will have material at bedside to do a bedside swallow screen before we give any food, medication, drink. And we also provide them, we use red folders for our patient education, and we make sure that's at bedside on their arrival. Now, I apologize. I was going to show a video here, but I lack the ability to share my sound on this platform. But it was a video going over how we work how we perform our multidisciplinary rounds. We do them each day at the same time, hitting, as Betsy said, I cover 2 units, which are 64 beds, and we go over those patients within an hour by service lines. And in attendance, we have our prescriber, we have the bedside nurse, we have the charge nurse, we have pharmacy, we have a representative from physical medicine and rehab, and sometimes we'll also have quality analytics staff as well. Now, when it comes to this team effort, it really takes this team effort for us to be promoting mobility, for us to preventing falls, for us to do pressure injury prevention, VTE prevention, to do infection prevention, nutritional promotion, and education. There is quite a bit that we do to have the best outcomes possible for our patients after a stroke. And this is everyone involved, from our dietitians, our respiratory therapists, our pharmacists, and our environmental care workers. It takes a team to take care of these patients. Now, we know that there is quite an impact of having stroke centers, that with these acute care plans and standards of care, we have benefited all patients that have had a stroke, whether or not they receive thrombolytic therapy. So in the literature, there are 3 interventions that have been demonstrated to improve outcomes of stroke patients with a number needed to treat of 6. What that means is that if we do these interventions for 6 patients, 1 patient will have an improved outcome, compared to giving IV alteplase or TPA, which has a number needed to treat of between 6 to 18. So these 3 things are things that we want to make sure in the first 72 hours we're educating our stroke nurses about this bundle of care, so that 1, we're making sure that swallow screen is performed before any oral intake is done. We are making sure we do temperature control. I'm going to go into more details with these. And lastly, that we do glucose control. And we know, first off, when it comes to dysphagia, it is quite common in acute stroke. It ranges in the literature from 29 to 81% of patients after a stroke having dysphagia. As well, of those that have dysphagia, approximately 50% of those patients are going to aspirate. And of those 50% that aspirate, a third of those patients will require treatment for pneumonia. It's so important for us to have that early identification to avoid complications of dysphagia and aspiration, right? These patients could have medical complications of pneumonia. We are in the literature, it shows longer length of stay, a poor quality of life, and actually reduced functional outcomes. So we just make sure we are reinforcing with our staff that nothing can be given to the patient until they pass. We reinforce if the patient needs, let's say their aspirin, if they're not able to swallow it, we will get it ordered rectally, or if it's appropriate, we'll make sure we put it in an NG tube to be able to give it timely. We have a neuro inquiry committee. So in our hospital, we have 3 units for the neurosciences department, and we have bedside and advanced practice staff from all 3 of these units. And we did an EBP looking at what are the best practices to prevent respiratory deterioration for hospitalized adult neurosciences patients. And what the literature says is having enhanced oral care protocols had a positive impact on non-ventilator hospital-associated pneumonia rates and deaths. So for us, we created a quality improvement project. The first goal was to improve the quality of oral care. So what we did hands-on staff training, going over the technique, as well the time frame that is recommended for brushing your teeth, taking 1 to 2 minutes. And we want to make sure that we are not just swabbing the mouth. We wanted to elevate that level of oral care from swabbing to actually physically using a toothbrush to clean the patient's mouth, and then suctioning to make sure the mouth is as clean as possible, as it is so important before we do a bedside swallow screen as well in our patients. So first, we want to standardize what's that quality of oral care we're going to provide. Second, we wanted to increase the frequency of providing oral care 3 times a day to 55%. Now, most people, like you and I out in public, it's recommended to brush our teeth twice a day. But a lot of the literature for non-ventilated patients, it recommends 3 times a day, especially after meals. And when we looked at our baseline data for how often we were providing 3 times a day oral care prior to the project, we only had about 5.5% of patients getting 3 times a day oral care. And this takes a team effort to achieve 55% for 3 times a day, because 2 of the frequencies will happen on day shift, the after breakfast and the after lunch. And then the brushing of teeth before bed requires night shift to be as involved as well. We would give credit also for documentation by occupational therapy or speech language therapy for them brushing the patient's teeth as well. And over the last 3 months of our quality improvement period, we were actually able to increase the 3 times a day oral care from that 5.5% to actually 56.8% as the average for the last 3 months. So our next goal was, can we decrease our number of emergency response team activations due to aspiration by 20%? And we were able, in the first year, we were able to decrease it by 23%. And for our project, actually, the first year, we have quite a few patients that are at risk for aspiration with dysphagia. We implemented it only for patients that were on tube feeds or were MPO due to dysphagia. After the first year, we expanded it to all patients at risk for aspiration pneumonia that had dysphagia, regardless of what their diet was. So we were able to decrease it by 23% in our first year, an additional 8% in our second year. And I only have the data through May of our third year, but we've actually been able to decrease it so far an additional 31% by truly improving the quality and frequency of doing oral care for our patients. So for the best practices for aspiration precautions, as I've said, we make sure we do that swallow screen before any intake. We make sure we have suction set up in the room. Actually, before the patient even shows up, we want to make sure that's already set up for them. I just went over our oral care protocol, so we want to make sure we are brushing every patient's teeth before in the morning and before bed, but for the patients at risk for aspiration, we want to do it 3 times a day. For our patients, especially those that are on tube feeds, we want to make sure the head of the bed is minimally at 30 degrees or higher to decrease the risk of aspiration of their tube feeds. We also follow up and communicate with staff about strict adherence to the swallowing strategies that our SLP colleagues recommend to do for our patients. So SLP has created these pink signs that we post in the patient's room, and these pink signs go over what the recommended diet is, the liquid, the recommendations for how to give the patient medications, and strategies, because we know some of our patients require strategies such as pocketing, doing a head turn, chin tuck. So for us to ensure the safety of patients when eating, SLP are really helpful to make sure that we have the same plan in place and we communicate that well. Rather than having to dig through the chart, we have these signs posted, they put the date on it, and every time they update it, they put a new sign up. As well, sometimes that recommendation is for one-to-one feeding. And we kept having patient safety events where our nutrition staff were delivering the trays into the patient's rooms. And as we're all aware, if you put food in front of a patient, what are they going to do? They're going to eat it. So what we put in place is we created signs that go on the door. So it tells our nutrition staff to stop, that they need to deliver the tray to the nurse's station so that a staff member brings it into the room. As well, we updated our computer system so that the meal tickets and the diet orders also have the special instruction to deliver the tray to the nurse's station in case patient movement happens and somehow the sign doesn't follow the patient. That nutrition was still delivered to the nurse's station to ensure that a staff member is providing it to the patient. For temperature control after stroke, we know that fever worsens outcomes by increasing the metabolic needs of the brain, and that for every 1 degree rise in temperature, the risk of a poor outcome for our patients will double. The greatest effect is in the first 24 to 72 hours. So we really want to talk to our staff to make sure they know that we need to aggressively be treating our patients with acetaminophen or physical means with such as ice packs and like removing of excessive blankets. Our goal is for our patients after stroke to be afebrile, and we also want to prevent shivering because that's going to increase the metabolic needs of the body as well. And we'd rather have these patients after a stroke be working on stroke recovery. Goes hand in hand with temperature control is we want to prevent these patients from getting an infection. So whenever we can, we want to remove unnecessary invasive lines like central lines, urinary catheters as quick as possible. We want to make sure all staff are doing hand hygiene going inside and outside of the room. At our hospital, we actually have secret shoppers that are monitoring, and we are given scores each unit for the different types of staff going into rooms and whether we actually used like a Purell or washed your hands before going in the room, and if we did so on coming out as well. And then, of course, we want to make sure we're following strict isolation guidance, educating our patients and their family members to that as well, so we don't have any spreading among the unit. As well as we bring in supplies to patient rooms, we want to make sure as we take them to another patient room, we are cleaning them on the way out. For glucose control, as well, we can have worse outcomes after a stroke for those that are diabetic and that have an acute hyperglycemia at the time of infarct. So we're going to monitor the blood sugar on admission, and once they come to our stroke unit, our goal is to have their blood sugar be less than 140. For lab work, we're going to get our patients hemoglobin A1C, and for many of our patients, we'll ask how well they are doing with controlling their blood sugars, and they'll say, oh, I'm doing great, but their A1C tells us another picture with a score of 16. We make sure these patients are ordered for the appropriate carb control diets, and then we provide them with education. Sometimes we can get our dietitian to provide them with some education, as well as getting some additional things from nurses as well with regards to controlling your blood sugar and your diet. For mobility promotion, so we've created the individualized, or we use the individualized daily mobility goals based on the patient's 6 clicks, their AMPAC mobility score, and that in alignment with the Johns Hopkins Mobility Goal Calculator. What we do is we have our staff document the highest level of mobility at the end of care. So whether your patient's transferring to another unit, or it's at the end of your shift, because the next shift is not going to know what happened while you were taking care of the patient. We document the patient's highest level of mobility, and we monitor this. So we have a data, we call it Tableau, that you can see at the bottom there, where for each level of mobility, we get report cards of how well we are working towards achieving goals as a unit. And we get information over 6 months, 3 months, and each month to know how well we are doing with having patients achieve their goals. We also have worked to increase the equipment we have available to help patients achieve mobility goals. So our units have a device called the convolizers. We have sit-to-stand devices. We have walkers in every patient room because we know when things are close to bedside, we are more likely to use it. Whereas if all the walkers were in the closet, very few staff would go and get it. We also have unit-based champions that go to additional training with the AMP program, and they talk at our huddles to talk about what we're working on this month to achieve our mobility goals. And then, as I said, we monitor our goal achievement to get our unit to mobilize patients as much to their capability as possible. What goes hand in hand with mobility promotion is fall prevention, and 14% of patients that have a stroke will have a fall in the first month. So we want staff to be really aware of what are your patient's risk factors, and not only our staff, but the patient should also be aware what are their risk factors as well. As we age, it increases our risk of falling, our cognitive impairment. If we have our inability to know that we have deficits, if we have mobility deficits, if we have neglect and we're not paying attention to half of the room, half of our body, if we're on multiple medications, if we have a history of falling, and then of course having urine or bowel incontinence or urgency are also going to increase the risk of a patient trying to get up to fall. Things that can increase the risk of injury would be your patients that are on bleeding precautions, maybe our patients with atrial fibrillation or anticoagulation. They could be of advanced age, and with advanced age, they could also be at fracture risk as well if they have osteoporosis. So for fall prevention, we want to make sure every patient every day is getting a fall risk screening. We also do delirium screening. So on our stroke unit, which is a non-ICU unit, we use the 4AT screening form for delirium. We also promote purple surrounding. I have a little thing to the right there. Purple surrounding has the 4 Ps. So it's proactively meeting patient needs to prevent falls and improve patient satisfaction by proactively addressing patients' pain, positioning, because we will have patients that are in the chair that may try to get up to go to bed on their own, or vice versa, from bed to the chair. So we want to make sure they're comfortable. Proactive toileting, and making sure personal belongings, because patients will perhaps try to reach for their personal belongings and can fall in that. So our goal with this is that during the daytime, every hour, a staff member is going in and offering these things to the patients. On night shift, we do it every other hour. If the patient's sleeping, we don't actually have to disturb them, but we want to make sure there's also that peace of mind that the bed alarm is on for these patients. We also, for patients that are showing signs perhaps of having some cognitive impairment or are positive for delirium, we want to use best visual location. So if it's best to move them closer to the nurse's station, I'm a big fan of having doors open. I can't tell you how many times I've walked by a patient room when a patient should be parallel to the bed and I see them perpendicular, and I know no patient should be perpendicular. And this just allows myself and anyone else walking by to quickly address a patient in a position that could lead them to falling. We also can use constant patient observation, and our hospital within the past few years has also purchased telesitter services so that we can have someone remotely be watching on camera patients and speak to them in the room and alert us with alarms if the patient were to perhaps be trying to be getting up or anything like that. For equipment we've purchased, so we have our beds come with bed alarms, and we make sure they're plugged into the walls at the head of the bed so it alarms throughout the unit. We use chair alarms as well, and then we have purchased floor mats so that for our patients that are at greater risk of injury, so those with advanced age, bleeding precautions, and those of our patients that have that are positive for delirium or have cognitive impairment, that we are proactively putting those beside the bed so that if they were to fall, hopefully we could prevent an injury from happening. As well, for patients that are high fall risk and that have possible have cognitive impairment or positive delirium, we will set the bed alarm at a more sensitive level instead of the least sensitive level. I talked about mobility promotion, but it is so key to try to prevent our patients from becoming deconditioned while they're in the hospital. We also have unit-based fall prevention champions that will do audits of our best practices for fall prevention. And we also find it's highly important to talk to patients and their family to engage them in fall prevention. So one thing we had an issue with, this was in 2024 fiscal year, we had a concern because we were seeing an increased number of falls on our 12-bed stroke unit. So this unit has 32 beds, and over 50% of the falls were happening on the 12-bed stroke unit. And so with this concern, we updated our policy so that all patients on the stroke service will be an automatic high fall risk while in the BRU. As well, we made it so that we, as I said, we set that bed alarm on a more sensitive setting if the patient has a 4AT, which is our delirium screen, greater than 0. We increased the use of our telesitters, and we purchased 8 fall mats. And then for our fall prevention champions, we use the K cards, which are real-time audits. And we use these to focus on our practices that we need to improve our audits on. So that would be our bed alarm compliance, our delirium screening, and we're working to, it's a fluid K card, because most recently we're really trying to encourage that the doors are open for patients that are high fall risk. So I'm going to show you what this ended up doing. So for our patients on the stroke service in our stroke unit, we can see year after year, we were seeing that increase in falls and falls with injury. And by implementing all of those, last year, we only had 2 falls for patients on the stroke service and only 1 suffered an injury. So we had an amazing improvement by really highlighting this high-risk patient population on our unit, putting in those interventions and seeing an outcome. For pressure injuries, it's so important to do daily skin checks head to toe, making sure we're turning and positioning our patients, ordering specialty low airflow beds or overlays, using pressure reducing chair cushions when they're up in the chair, floating our heels. And we really try to stress with our staff that you could put, a pillow underneath someone's calf, but if their heel is still touching the bed, we are not doing the actual job of floating the heels, because our biggest areas we've seen with wounds are the heels and the sacrum. So we also do the silicone adhesive foam dressings on the sacrum and any other concerning pressure point areas. We really work with nutrition to promote nutritional intake. And as soon as a patient has a wound, we're notifying the team, we're putting in a wound care consult, and we're notifying nutrition so they can make adjustments to the patient's nutritional recommendations. As well, we do weekly skin rounds with our wound nurse and our champions. So on our floor, we do some of these rounds it's done once a week, either on night shift or day shift. And they go to our highest risk patients looking to see, do we have in place all the best practices to prevent a pressure injury and ensure they help with the recommendations for wound care as well. Our patients are at risk for venous thromboembolism, so we make sure on admission we put on the sequential compression devices. We're going to give our patients the subcutaneous heparin or low molecular weight heparin as it is ordered for them. We actually have also a database also looking at our compliance with that and how many times patients refuse versus how many times it is not given, because we want to make sure we're doing our due diligence. We know that having STDs on the patients and using pharmacologic prophylaxis, it decreases the risk of the VTE by 60%. And then, of course, we're going to be monitoring our patients for any signs and symptoms of a deep vein thrombosis or a pulmonary embolus. Lastly, that is so important to the quality of a care we provide is that every day, every shift, we provide ongoing stroke education to patients, family, visitors. We want to get the word out about everything you need to know about strokes, right? It is so important to have public awareness for the warning signs and symptoms of a stroke. I've had a visitor who I went over the signs and symptoms, and they said to me, that happened the other day. So people downplay these symptoms. So it's so important, anyone who comes to visit, that we are reinforcing those signs and symptoms. We want to go over the patient's individualized risk factors for stroke. We want to go over how and when to activate the emergency medical services. So we make sure that's also a part of their after visit summary for their discharge paperwork. For their prescribed medications, anything that is to do with preventing another stroke from happening, we reinforce on discharge. So that would be the antihypertensives, the cholesterol lowering agents. It could include patients that are started on SSRIs, but we want to make sure we're preventing this patient from coming to the hospital with a stroke again. So we really focus on those prescribed medications on discharge, making sure patients can fill them, that they know what they're for, the importance of taking them. They know the last time it was given before they leave and the next time it's due. And then lastly, it's so important to have patients not come back with another stroke because we want them to follow up as an outpatient. So it's so important to try to set up for appointments and visits and have that on their discharge paperwork. So they have that one-stop shop of where to go for the information that reinforces the signs and symptoms, the risk factors, how to activate medical services, prescribe medications, and that need for follow-up after discharge. And I know we're going to ask questions towards the end, so you can put them into the questions, and I'm happy to answer them at the end. Thank you.
Right, thank you, Lisa Klein, for that great talk on nursing care in the stroke unit. I would like to welcome Dr. Zena Khoury, who will talk about nurses as stroke advocates and educators building leadership skills. Dr. Khoury is a distinguished healthcare executive and nurse consultant with extensive experience in transforming healthcare systems across emerging markets. She has led complex partnerships with major institutions such as Johns Hopkins Medicine, Saudi Aramco, and Emiratis Hospitals as managing partner at Emerging Health International. And she's also the founder of Saida Akhtar Clinical Institute. She champions clinical training, nursing advancement, and innovative care models. Dr. Khoury holds a BSN from American University of Beirut, a master's in critical care and trauma from the University of San Francisco, and a PhD in nursing from the University of Maryland, where her research focused on critical thinking and clinical decision-making in extensive care nursing. Welcome, Dr. Khoury.
Thank you so much. Thank you. Can everybody hear me? Is this okay? I think
Yes.
good. Okay, perfect. Thanks for the introduction and thanks. It's so nice to see some familiar names and faces. I haven't seen you guys in a long time, but it's great to see each other this way and hopefully in person sometime soon. I have the privilege to talk to you for a few minutes, and I'm going to take it a little bit from a different perspective. I listened to Lisa's great clinical insight and all of that. I am going to talk about nursing and the nursing role, but more from a programmatic, from a leadership and other perspectives. So please feel free to ask any question, unless we're doing the questions. But you know what, Brenda, I see some hands raised. Do we want to?
So we're gonna save all our questions until the end.
Okay, so we're saving
Okay.
all the questions till the end. So
Yes, that is correct.
who reads would know that. Okay. So talking about the nurse's role, as we all know, the nurses play a vital role in overall stroke management. So I'm focusing more on the overall in preventing stroke complications in patients by providing more of a comprehensive care. Multidisciplinary care we just described. This is more of a comprehensive care from incident to after discharge to prevention to all of that. And what's the nurse's role in doing all that and tying all of this together, whether it's the hospital, the clinics, the EMS systems, or the post-discharge system, rehab, and all of that. And I'll talk about a little bit, in different countries, how it's done differently and why what we traditionally and still call stroke coordinator is very, very important. The stroke coordinator role is very important. We developed that years and years ago at Hopkins, and we've been very lucky with many of our stroke coordinators. However, that's not the case all over the world. So in a lot of places, that is not something that's looked at. The nurse's role is not elevated to be that anchor for the patient, to be that person that helps the patient in everything. So I'm just going to start with assessing and monitoring. As you all know, the role of the nurse is very important. Vital signs, medication administration, paying attention to their side effects, neurostatus, things that if you haven't been a neuronurse or if you've never seen a stroke patient, you would want to focus on swallow and speech. Incontinence, skin integrity, mobilization, and the psychological factors. These in a lot of countries in the West have been taken for granted, but may not be the same case in other places. you know, so it's not the usual, when we say assess vital signs, you don't assess them like you assess for every other patient. When you look at neurostatus, you look at a lot more details. You know, it's very important to look at the vital signs the first 48 hours, and more so the first 24 hours. Hypertension is okay with stroke patients, which still scares any nurse who has not done neuro. You know, it is, though it is debatable, it's still very important to make sure that the patient remains hypertensive in the first 24 hours versus, you know, controlling their blood pressure to the beautiful 120/80 that we all strive for. But that's not the case in stroke patients. So neuronurses, this is where they play a vital role. And this is where they need to make sure that they educate not only their peers, but the patient and the family, that when you see that number, though it looks very high, it is not, it's really what we want and what we go after. The neurologic status, we really want to focus on mental status, and that goes beyond the GCS score, that goes beyond everything. And it is really more coordination. We have motor examination, and the coordination and sensory examination become very important. Again, these are done intensively the first 24 hours, 48 hours, but they carry throughout, and even in rehab, they become very much more important, especially if you have motor deficits or sensory deficits. Medication management is also very important, and it's more than, let me look at the order and give the medication. It's a lot more than that. It takes into account reconciling all the meds that the patient came in. And, you know, we don't have the luxury of, a lot of times we don't have the luxury of connected EHRs or a patient portal or a patient population that really knows how many meds they take. They say, oh, I take 4 or 5 pills in the morning. Okay, what are they? How would they interact? What did you stop? When did you stop it? Do you take an anticoagulant? What do you know, and so on. So it's really important to focus on antiplatelets, anticoagulants, cholesterol lowering drugs, and blood pressure medicine. And these, as you give them, and I always tell my nurses, you know, outside of the US, because we took it for granted, you know, explain to the patient how important this medication is, how important it is to keep taking them. I can't tell you how many times patients get discharged, and they're very highly educated patients, but I'm tired of taking those meds. I stopped taking them. So it's really not, you know, it's very important. This is where the nurses can play a very vital role, even post-discharge. Those phone calls that we took for granted, you know, call the patient, ask them how they're doing. Are they taking their meds? Send a nurse home to them to check their pill box, give them a pill box when they leave, to train them to put their meds in there. It's those little things that can make a huge difference for the patient. That's one example in medication management. We'll talk about others. Nutrition and dietary education. Again, a lot, I heard Lisa say about nutrition and get a constant and all of that. That, though it's the norm in a lot of places, it's really something out of the ordinary for other countries, right? So we need to make sure that nurses work with dietitians, that their voice is heard. When they think they need a, you know, this patient could benefit from a low cholesterol diet, and then make the diet culturally sensitive. Don't tell them to take things that they cannot find. Don't ask them to eat things that they probably would not have in their fridge. So let's, you know, make sure that you are able to lower their cholesterol level, manage their sugar within the cultural norms of their dietary intake as well. And no one but a nurse and a good dietitian will do that for you. Fluid and electrolyte balance, this is huge. You'll be very surprised at how many dehydrated patients we get. Dehydration is a huge issue. We don't notice that we're sweating consistently, and especially in areas where it is very, very hot and very humid. And it's year-round hot, for example. So people don't, you know, your body does not adjust. Or if you're coming from a different country and you know, you just moved into a very a different climate and all of that. So just make sure that dehydration, with stroke, dehydration will happen. Let's make sure their fluids and electrolytes are managed, push their fluids and their electrolytes as much as possible. And then make sure they're well hydrated and their electrolyte balanced. You know, it's people don't think of it, but you know, it's just sometimes drinking only water is not enough. So let's make sure we keep an eye on their labs and explain to them what needs to be done and all of that, and so on. Wound care is really important. And that's also, you know, preventing pressure ulcer. These patients become, as you know, immobile. So providing wound care, making sure they don't get a pressure ulcer, promoting healing is very important. DVT is also super important. You know, the patients are, again, may not be as mobile as they were. So let's make sure they're not, and they may or may not be on anticoagulant. So make sure that they are taking their anticoagulant and it's monitored through PT, PTT, or an INR, and that they have means to make sure that they still even passive range of motion or any, they have their TED on, they are able to find ways to make sure they prevent DVT. And I also heard about talking about fall prevention. Most stroke patients will fall the first a few days, and so making sure that fall prevention is done, and you know, talking to them about fall prevention, making sure you do your fall prevention, and assess them for fall risk. Most of them will come back as high risk, but let's make sure that we are implementing things that make sure that will prevent their fall. So all of this put together, you know, I didn't tell you anything you don't already know. You probably already know this and why, but the role here is pivotal because you are coordinating all of these things. You're the one person as the nurse that will know to make sure, okay, let me call PT, let me call speech, let me make sure nutrition is here. So that case management role or care coordinator role will fall upon the nurse. It is sometimes unusual to have case management in hospitals. It's not a traditional role in some parts of the world. So it becomes that nurse at the bedside that becomes very, very important. And this is where your coordination and your leadership of that patient, advocating for that patient to make sure that you are the person that's looking at the big picture, at the whole picture, and not just, okay, they're taking their medication. All right, this bleed didn't get better. Okay, they didn't fall. Okay, these are great things, but what are they going to do once they leave? What is going to happen to them? How much deficit are they left with? Physical activity, what physical activity do they need? Do they need an occupational therapist, a speech therapist? These are not easy to find. Do they need devices at home? Again, some places, these are very difficult things to find. So having that nurse coordinator role, from even if at the bedside or as a charge nurse, or so don't wait and look for, well, there's no case manager, so I'm not going to do much. It becomes your more incumbent on us as nurses, as any bedside nurse, to help with that. Psychological support is huge. Again, stroke survivors may experience emotional and psychological challenges. They may not even tell you they're feeling this way. They may be very sad and depressed, but they're not able to. So again, the nurse has to provide that emotional support, but more so facilitate them being able to speak up about it, and then having ways to find the support for them, for mental health support, especially in countries where it may be a stigma, and it may be difficult to find support for mental health. It's very important that we play a role in that, you know, listen to the patient, find out what they really need, and facilitate finding them something. So what we're talking with, this is important. Why this is important? Because it's a combination of everyone that's going to make this happen. You know, it starts from, it's the whole continuum of care that we always talk about, whether it starts with screening, with follow-up, with let's make sure that EMS knows what they're doing. Everybody has a role and plays a role, but the one person that has that oversight, who I always say is the common denominator, is the nurse. So it's very important to have that and make sure you coordinate. So nurses are advocates for their patients, and more so for stroke patients, especially in immature stroke systems where everything's disconnected, and you have to find things, or you have to find the resources, and the patient may not know how to find these resources, may not know what to ask for. So it's the nurse that goes out there and finds those from a holistic care approach. Educating the not only the nurses but also the patients is very important. So now the nurse would have to play the role of the patient educator as well, and the family educator. This is what's going to change in your life. Some strokes are devastating and are very life-changing. Others are minor and it's okay, but they'll still have some deficit. So finding out really what those deficits are and how to manage them and how to handle them is very, very important. The other thing is, find out what other, I don't want to say the word is not comorbidities. What other things can you do to prevent them from a repeat stroke or from extenuating? So let's make sure that smoking cessation is addressed. Weight management, stress reduction techniques, all of these things have to happen. If you escape the stroke and you're doing well, doesn't mean it's not going to come back. And I always tell the patients, we need to work on these things. And smoking cessation, though it's much more progressive and much more ahead in the US, here, it's still something we suffer from. Like, we need to make sure that we plug them into programs for smoking cessation post-stroke. Weight management is a big issue. And stress reduction, it all comes back to admitting you're stressed, admitting you need help, and finding them the right psychologist or psychiatrist to support them. So this is where the stroke coordinator role is born. So whatever you label it, whatever you want to call it, whatever title, in certain countries, this is a difficult title. Case management is a very difficult title. Whatever you want to call it, what you are doing as a nurse, you are becoming the stroke coordinator. The one thing we missed to talk about, I've been talking only about patient. What I would love to see is for that nurse stroke coordinator to play a vital role, not only in improving patient outcomes and the patient care, but also improving the center itself, the stroke center itself, the stroke, where are what best practices can I implement? What are some evidence-based practice things that we can put in place? What is some data that we collect? Not everybody has a stroke registry. What can I do to make sure that we do have a sense of how many strokes we get a year, who's more vulnerable to a stroke than other, and all of that. So all of that piece is missing in a lot of parts of the world. So I think stroke coordinator plays a vital role in program management as well as patient management. Patient management we may do better at, and we start with that always, but I think it's time to start looking at program management and start looking at how am I going to be, take a leadership position in the stroke center, because it is not all about, making sure everybody's doing the right thing by the patient, but also you want to do the right thing by the rest of the public and by the stroke center itself. So they're your person that is doing program management. So they maintain and support the stroke center certification or accreditation. If you are living in a place that you do have a certification, primary or comprehensive, that's your key. That's the person that holds the key to that. And I've had the privilege of working with great stroke coordinators. And that makes a huge difference. They are the people that are making sure the guidelines are implemented, the data is kept up to date. They do everything, and they coordinate between departments, not only when there's a patient, but at all times. So we know how to work in a multidisciplinary team. They do have clinical oversight, so they oversee the nurses at the bedside, and they make sure that they are doing the right things. If you do have a system where you have a code pager or stroke code, then they are the ones that are carrying that. to make sure that the patient is getting the care they need within the hour, within the 60 minutes, within the 3 hours, and so on. And they document, they help make sure all the documentation is done, all the timestamps are there, and they do the data collection. And the data collection is not only for a registry, not just for, but it also gives us information on demographics. I just moved jobs and moved to a country where the first question I had is, what are the demographics on here? How do I know what chronic diseases are? How do I do chronic disease management? And the data was just insurance data. There's just no country data. There's no registries to speak of. So if we had the ability to go to every stroke center and have that person that can collect the data through the guidelines, through using national registries and participating in them, then that gives us a whole plan for the rest of the country. And that is a great role for the stroke coordinator. They lead all the quality improvement initiatives, and they are responsible for their program and their initiatives, and they present at the highest level. They can present to the board, they can present to executives, and they head very important committees. They also provide education and training for the nurses, for the bedside nurses, for the EMS, for the public, for ancillary staff, for speech therapists, for everybody. So all these protocols that we've spoken about, these need to be trickled down. These need to be educated. And typically a stroke coordinator who has vast experience in taking care of stroke patients does that really well. They serve as a liaison between everyone, like we said, all the departments, especially when there is a stroke patient, but also when there isn't. And they also head committees and make sure that their committees are multidisciplinary. So everyone is benefiting from that experience and that coordination. I just put in there some qualifications. I think some of us take those for granted, but it is important that this nurse is an advanced practice nurse, is licensed as a nurse, has experience in neurology or emergency medicine, critical care, or rehab, has knowledge of stroke standards and clinical pathways, and has strong analytical and organizational and communication skills. It would be ideal if he or she has a stroke certification, as a master's degree, can practice independently, but not all countries have that. And then they have some experience with accreditation somewhere, some kind of accreditation. They are very instrumental, like I said, they are become part of the leadership team. And the success of every stroke center will depend on that role, on that nurse's role, that leadership role that the nurses can take. So in conclusion, I think there's a huge impact. The impact of the stroke coordinator is an essential one. They are leading a stroke center, especially in countries where this is new. We need good stroke coordinators. They are essential in ensuring patients receive the rapid care, the evidence-based practice, the guidelines, the treatment. They are essential in making sure staff is trained and educated, and they are essential for the survival of the program itself, of the stroke center itself, and of the data and the benchmarking. Thank you so much for listening, and I hope this was helpful. And let me stop sharing for a second. Okay, and then like we said, we'll leave questions till the end. Thank you so much.
Thank you so much, Dr. Corey. And I would now like to introduce Maha Aliwad, who will present the last lecture of our session on the role of nurses in stroke prevention and risk reduction. Maha Aliwad is the Executive Director of Nursing at King Salman Specialized Hospital and a neurocritical care nurse specialist with 18 years of experience. She serves on national committees as a board member of the Global Sepsis Alliance and leads the nursing chapter of the Saudi Stroke Society. She is a recognized speaker and published researcher. Her interests include sepsis care, sedation, delirium management, and stroke systems. She was awarded the Golden Woman Award for the Most Inspiring Woman in Healthcare in 2023. And it is my pleasure to welcome Maha Aliwad.
Thank you so much. Is my voice clear?
Yes.
Okay. And it's my pleasure to meet you all and reconnect with some of my colleagues. Please let me know if the screen is clear. I'm sharing my screen.
Yes, the screen is clear. We can see your slides.
Okay. So talking after Dr. Khoury and my colleague, Dr. Lisa, I think there will be a lot of repetition about the critical role of the nurse in stroke prevention and treatment. However, the aim of this probably very connected, the three topics, is to re-emphasize on the importance of the role of the nurses, not only in early recognition, but also in prevention, not only in managing acute stroke, but also what is the post-stroke care. So we're going to talk about some background information about stroke care. What are the primary prevention strategies and secondary prevention strategies? How, as nurses, we can serve in stroke preventions, and then we're going to touch base on some of the practical recommendations that can be applicable to different healthcare institutions. So stroke, as we all know, is the second leading cause of death, as well as is one of the top leading cause of disability worldwide. And the burden goes beyond only treating stroke care. It's actually getting patients back to their communities, getting their family involved, investing in a lot of rehabilitation and integration of care. So that talking about system of care of stroke, it's a long journey for countries with well-established healthcare systems, and it's even more challenging when we're talking about countries with very limited resources or low income. So the stroke is actually a major health burden worldwide, and the stroke care is expensive care, and that's why United Nations, WHO, actually encouraging policymakers and government officials to take care of stroke as serious as possible, as one of the top leading costly disease, I would say. So stroke prevention is a key strategies to prevent treating complication of stroke. And when we're talking about prevention, we're talking about different level of prevention. Primary prevention, where patient is not at risk, and secondary prevention, where the patient have a lot of risk factors that we need to modify. He or she might have a previous stroke or TIA. And then we're going to talk about why stroke prevention require understanding, because it goes into a large scope, and we as nurses play a major role in the stroke chain of care and system of care. So when we're talking about chain of care, the first step to treat patient with a stroke is actually to recognize he or she having a stroke. And then this mobility or mobilizing the patient or taking the patient to a healthcare facility that can actually provide stroke care, including administration of thrombolysis therapy or managing patient with thrombectomy for last occlusion if the patient get out of the therapeutic window for the thrombolytic therapy. And then timely management. It is really important to reach the emergency department on time. It is really important to have a stroke code activation and well-coordinated care between imaging department, emergency department, a stroke unit, to make sure that the care for this patient is as efficient as possible and the time is as close as possible. Post-acute stroke care is also another important pillar of stroke care, where the patient post-acute, he will need intensive rehab. He could also need a long-term outpatient rehab and more integration programs into the community. Maybe they might need some changes in their house furniture, structures of the house to make the environment safe. Lisa had covered a lot of complications that those patients at risk of fall and immobilities. So it's really important to facilitate the system of care across the continent to make sure that we're providing safe care for those patients. So when we're talking about safe care, we will have to think about stroke prevention as an integral pillar of the safe care for those patients. We usually focus more into the acute side of the stroke care, where the patient rushed by families or EMS to the emergency department. Emergency team has a well-established protocols that they take the patients directly to a CT scan, get an initial report, and identify is it hemorrhagic versus ischemic, and then follow up with the management plan based on the imaging findings. That is easy to say, but hard to do if the system of care is not really well coordinated, if the guidelines and the hospital policies are not clear and shared, and there are a lot of rehearsal, simulation, and training for staff members to understand it. So it's really important. Nurses in emergency department have a vital role in not only in saving stroke patient life, but also to train their colleague from EMS and imaging, how important it is to keep on tracking with the timing. It is really important also to communicate with second level of care after emergency. Is the patient going to a stroke unit or ICU? And what would be the plan? It is really important to keep the patient and their families in the loop of decision-making and a plan of care. So when we talk about that, we have to know about the guidelines of stroke. And part of the guidelines of stroke, we're going to talk about particularly related to reduction of risk factors, as well as prevention or primary prevention. So if you look to this table, it's going to give you that there are certain stroke care elements that are necessary regardless if you are working in a comprehensive stroke center, a primary stroke center, or even a small hospital. So each hospital should have a public education program that teach the patient, raise awareness in the community about stroke signs and symptoms. Education is a key, but also it's very cheap, less expensive, more innovative. You can reach to patients and families at different level of settings, not only at the hospital setting. To raise the awareness, you can use media, you can use social media, you can use community gatherings, you can use events to raise the awareness, and it's really important. Second, hospital care in the hospital should be established based on guidelines and protocol, because that will facilitate coordination of care and implementation of timely management for the patients, as well as any stroke patient who arrive to the emergency department, regardless of the level of this emergency department, they should be able to do the simple ABCD and manage the patient and determine within the first 10 minutes if the patient will be managed within the capabilities of the hospital, or he or she need to be transferred to a higher level of care where safe stroke care can be provided. Next is about treatment of emergency hypertension. There are always a discussion about hypertension and risk factors of hypertension when we talk about stroke prevention. And there are always a debate in the guidelines, what should be your target blood pressure after thrombolytic therapy, what should be your target blood pressure after large vessels occlusion removal or after thrombectomy. But the key here, when the patient coming with emergency stroke or emergency hypertension, that we need to prevent a stroke. So what are the monitoring measures that we have in place to help to reduce the risk of the patient going to a stroke or hemorrhagic transformation after thrombolytic therapy due to uncontrolled high blood pressure? Simple measures include also glycemic control, as those patient blood sugar is controlled, and what is their diet, what is their lifestyle, did they have hyperlipidemia, did they have any risk of cardiovascular event, did they have atrial fibrillation, are they in any cardiac medications, and so on and so forth. So it's really important to go through the patient history, and when you are planning to establish a stroke system of care in your organization, you need to check this simple ABCDE of stroke care. So when we discuss stroke care, we should touch base on the stroke risk factors. Stroke is a package of diseases that one lead to another. So if the patient is obese, he is at risk or she is at risk. If the patient has uncontrolled hypertension, hypertension is a leading cause of stroke. If the patient has a history of cardiovascular diseases, especially atrial fibrillation, it's very linked for the patient to develop ischemic stroke. If the patient has uncontrolled diabetes, diabetes increases the risk of stroke by 27%. If the patient has inactivities or sedentary life, or they simply are not active, that will increase the risk to develop stroke. If they are a smoker, regardless of their age, that will also increase the risk to develop a stroke. And for sure, if they have a family history, that increase the risk to develop a stroke. And if they have a previous history of stroke, that will increase the risk for recurrent stroke. So it is really important for a primary care provider, a family practitioners, and the community nurses to look to the risk factors and educate the patient before they reach to the level that they're coming to the hospital with emergency condition of having acute ischemic stroke or hemorrhagic stroke. It is really important to re-emphasize on the risk factors for the patients. It is really important to refer them to dietitian to monitor their diet, engage them in physical activities, treat and diagnose obstructive sleep apnea because it's increased the risk of stroke, counsel the patients who have heavy consumption of alcohol, smoking, or using of recreation drugs, refer the patient to endocrinologist, clinical pharmacist for the patient to make sure that they have well control of their blood sugar, regular follow-up with cardiovascular disease management clinic if they have a cardiovascular diseases, treat their medical conditions such as high cholesterol level or high blood pressure. All these factors together are really important to be addressed and treated to prevent secondary stroke, as well as to prevent primary stroke from happening if the patient have any of these risk factors. So when we talk about primary prevention, it is really important to understand that primary prevention goes beyond managing actual stroke risk factors to what are the system of care, what are the government regulation, what is the community service that are available out there that will help organization to basically implement primary stroke prevention. Primary stroke prevention is a large term that focus on environment, removal of pollutions, motivation for active lifestyle, availability of walking areas, availability of playgrounds for the kids, counseling for smokers, availability of smoking cessation clinic, availability of qualified healthcare providers that can be reached out through platforms or applications, or they are available probably 24/7 to communicate with patients who have concerns or questions, reaching out to schools and educate kids, educate teenagers about utilization of smoking and drugs that could increase the risk, about their consuming of junk foods and high cholesterol diets, all these important measures that need to be implemented to reduce the risk. Having campaigns to reduce smoking cessation and restriction on tobaccos, adding tax for tobacco products, alcohol products, investing in these tax revenue to improve primary prevention campaigns and projects within the society are really important. It is very important also to create a screening program in a public area, in a community clinic settings, to identify people at early stage of being at risk and try to manage their modifiable risk factors. We know that we cannot modify patient age or family history, but we have a lot of modifiable risk factors from diabetes to hypertension to smoking that can be managed and controlled way before the actual event or stroke is happening. When we talk about stroke prevention, as I mentioned, the primary stroke preventions, it should be as a national law and a government effort to improve the system of care, strengthening the primary health care and the community services to prevent actual stroke from happening and hopefully manage patient at earlier stage. This article is just summarizing of the Canadian guidelines about secondary stroke prevention, and it highlights what are the important measures to control and reinforce. So when we talk about blood pressure management, we know that hypertension is a major risk factors of stroke, and any reduction of or managing of blood pressure can actually improve and reduce the risk of stroke. So in this report, particularly, it documented that 10% or 10 millimeter mercury's reduction of systolic blood pressure and 5 with systolic blood pressure will reduce the risk by 34%. So that is an important aim for family practitioners, patients, and their families to work together to reduce their blood pressure, get their blood pressure data monitored, review their medication regime, reconcile with their medication, as Dr. Khoury mentioned, is really important, and then assess their baseline and target it to go down with the baseline for 10 to 15% in order to make sure that the risk is less. The other important things is to look for patients with persistent hypertension. What are the other associated factors, and what would be the level of care that are needed, or maybe extra medication that need to be added, and how the patient would respond to them, and closely monitor the patient response to these treatments. Lipid management is very important. Evidence shows that aggressive lipid reduction is actually improving the risk of reduction for stroke, and it's a very strong contributor to stroke prevention. Managing diabetes is another key. Patients with diabetes should be managed and follow up by dietitian, by endocrinologists, by family practitioners to make sure that hemoglobin A1C is under control, to make sure that they comply with activities of daily living and exercises, as well as they comply with the diet that is low in carbohydrate and low in fats. So patients with diabetes, they have high risk to develop ischemic stroke and TIA. And if their blood sugar is optimally controlled, that will particularly reduce the risk to develop acute ischemic stroke. It is also important to make sure that patients with cardiovascular disease history to have a 12-lead ECG to rule out atrial fibrillation. That could be in a patient presented to emergency department with actually acute ischemic stroke, or a TIA, or a patient who had a history of cardiovascular diseases to make sure or rule out cardiac causes or cardiac thrombus that lead to a stroke. Patients who have this investigation, usually when the patient has both TIA or acute stroke plus or minus cardiovascular disease history, they will put on a Holter for 24 hours to monitor their arrhythmias and manage the arrhythmias accordingly. And this is level A evidence, so it's really important for a patient with atrial fibrillation to be closely monitored for at least 24 hours to rule out the reason or the stroke cause. Talking again about stroke prevention, it is larger than only practitioner in the acute care setting or a community setting or a family member. And the story of stroke prevention is almost 20 years now. In 2011, the United Nations resolutions is to urge the WHO state member to have an action plan for primary stroke prevention as part of the huge burden, economical burden and healthcare burden, public health burden in the communicable diseases. So 10 years later, in 2021, the Lancet has published a very important article related to primary stroke prevention. And they mentioned that despite the effort from the WHO, the United Nations, for policymakers and healthcare leaders to address the risk of stroke at a system level, still the global stroke incidence is increasing and the prevalence is also increasing. In some countries, mortality of stroke is getting increased, and in another country where system of care is much better, mortality could decrease, but the level of disabilities, when you don't have a complete integrated system of care, could increase. So it is really important to address the burden of stroke in low-income countries compared to the burden of stroke in well-established healthcare system in the high-income countries. Dr. Khoury mentioned that certain countries, they don't have baseline data, they don't have demographic data, they lack registries. I'm going to speak about Saudi Arabia. Since 2000, 2015, there is a global mandate in the country that we have an action plan to create our own stroke guidelines and to create stroke registry and to get engaged with the stroke preventions and stroke awareness campaign. The Saudi Stroke Society is an active institute in improving system of care of stroke in Saudi Arabia. We have, I would say, improved tremendously. We move from there is no communication between EMS provider arriving with a patient with acute ischemic stroke to have a stroke en route where the patient have their CT and the ambulance for organization that have actually mobile stroke units, to the limit that the organization without mobile stroke unit, they will have earlier notification about the patient age, the patient risk factors, the thrombolytic checklist, the time of onset, as well as the estimated time of arrival, and they will bypass ER because all the ABCDE will be done in the ambulance, bypass ER and go directly to the imaging for the CT to reduce the time for either thrombolytic therapy or thrombectomy. So it is really important to acknowledge that over the last 10 to 15 years, Saudi Arabia has worked tremendously to improve the stroke system of care. We have the first draft of the Saudi stroke guidelines, and it's under revision for now. Now the Center of Board Accreditation for the hospitals, Sibahi, is also working to certify different level of care, either to a comprehensive or to acute ready stroke hospital or primary care stroke centers, and that will help us as stroke providers. It also helped our community, our families, our patient and loved ones to know when to reach out for help, where to go, what to expect. And it is really important to invest in awareness. And when I'm talking about awareness, I'm not only talking about awareness for the public members, but I'm also touching base in educating nursing staff, emergency nursing staff, community nurses, inpatient nurses, how to recognize a stroke, how to respond when they are suspecting a patient with stroke. So targeting risk factors is another important thing, and it's another multidisciplinary. You need a stroke educator, you need a dietitian, you need a physician, you need a nurse, you need a stroke coordinators, you need a stroke support group. Patients who went through the same experience, who can share their experience with the patient, encourage them how to get back on their feet and reintegrate them in their communities. So evidence that shows that public health studies indicate that adding also taxes to tobacco and alcohol and salt product is actually effective strategy for improving health. And that's not because when they are adding tax, it means a lot of people will quit smoking. I hope so this is the case, but actually it's to reinvest the revenue of these taxes into primary stroke initiatives and effort. Talking about our role as nurses, this is a study that was published in 2023 from Saudi Arabia, Jeddah, and it aims to look for how far we as nurses understand and practice within the protocol and the standard of care for stroke patients. And interestingly, that out of 131 who responded to this cross-sectional survey, there was a significant difference between ICU nurses responded to the survey and the stroke-trained nurses in the stroke unit, how they will respond to managing patient with acute stroke and managing patient stroke risk factor as well as post-acute phase. So the nurses who are not focusedly trained and working in a stroke unit, they show disparities in their answer to how fast they activate stroke code team when the patient has a stroke, how fast they respond when to apply the NIH stroke scaling and assess their patient neurological status, how they can identify patient functional status and using the patient modifier Rankin scale to assess. It's also important to identify that they were not able to recognize neglect syndrome, as well as they were not able to look for post-stroke depressions and allow the patients probably to express their feelings. That could be not the case when the patient actually in the ICU, if he or she is intubated and sedated, but when the patient is more awake, he or she can communicate with the nurse. And I think communication is a key to keep the patient engaged in their care, as well as to prevent delirium. It is really important to reorientate the patients and keep them engaged so they will be more familiar with their environment, and that will keep them more cognitively stimulated. So it is important to identify that we as nurses have something to do to educate ourselves, to raise the awareness among us, not only among our patient and communities. It is as important as improving awareness for public is to improve also awareness for healthcare providers. So the result of the study shows that there's an urgent need for stroke nurses trained in stroke, as well as it is really important to standardize stroke care across continent. I know the Saudi Council, which is basically the legislation body for practicing in Saudi Arabia, is working in creating a postgraduate diploma in stroke for nursing, and that will help, of course, increasing number of qualified stroke nurses that can serve our population. So when we talk about our roles, there are different roles that the nurse can play. Ms. Lisa has touched base in a lot of them, Dr. Khoury as well. So in the acute phase, the nurse has important role in rapid assessment and management of a patient with a stroke, whether with recognizing stroke by fast, identifying degree of stroke by NIH stroke scaling, managing ABCD and neurological status, monitoring patient response to thrombolytic therapy, identify if the patient has any complication of thrombolysis, hemorrhage, angioedema, allergic reactions, monitor the patient response, and then prevent complications, UTI, pressure injuries, pneumonia, aspirations. So the nurses have a lot of roles to do, and they also play as a liaison and coordinator between multidisciplinary team. We are the provider who are 24/7 with the patients, and our role is very critical. And a nurse is a link in every system of care, and particularly in stroke system of care. Nurses lead and participate in quality improvement project that enhance the quality of care for stroke patients and improve system of care at an organization level as well as at national or international level. In the subacute phase, nurses play a very important role in rehabilitation in collaboration with our rehabilitation colleagues. They assess in screening of patient functional status. They participate in exercise at the bedside. They evaluate the patient level of mobility and document the highest level of mobility that can be achieved. They follow up that the patient has actually proper occupational referrals as well as physiotherapy referrals. They make sure that the patient actually seen, patient actually visited the gym and have done their session for therapy. So the nurses has a lot of roles to play in rehabilitation. They also have a lot of role to educate patients and educate their families and to follow up with their colleagues at community setting. So it's really important to document and hand over care transition. It's very important, and putting strategic goals and realistic goals to improve patient care and individualized care plan for patients based on their age, their level of stroke, their level of education, and the level of care that they receive. It is also important that nurses at all levels, undergraduate, postgraduate, nurses practicing in the clinical setting or studying nursing, they play a role and raise the awareness for their families, for their communities, and participating in stroke awareness campaign is very important. It is really important for us to make sure that we should not take care that the information that we have and we took for granted is something that the patient, we assume the patient, they know it. Patient maybe don't know that their hypertension is one of their important risk factors to develop a stroke. They don't know that uncontrolled blood sugar is the key risk factors to develop a stroke. There are a lot of materials available that the nurses can utilize to speak and to educate their patient and to advocate for the right care of their patients. So I think our role is critical, and it is basically well recognized across the continuum of care, and we can do a lot for our patients to prevent them from complications. So recommendation to practice at a personal level, get yourself educated If you have the knowledge, if you are familiar, share the knowledge with others. At a system level, it is important to collaborate with different organizations, share experiences, invest in primary prevention at a community level as well as a national level, utilize stroke expertise and experience from other countries, and see what is suitable to your population to invest in. Prioritize primary prevention. It is way easy to prevent rather than to treat actual event. Establish an ongoing registries and awareness campaign. Look for warning signs and invest in prevention. So we as nurses, in conclusion, we play an important role of multidisciplinary team. We are a key player in each level of stroke system of care and stroke chain of care. Research found that with advances of treatment, it is really important that we keep up our knowledge and we keep up with our skills, yet prevention, basic, is a key. And we are, I would say, in a core of stroke prevention and stroke care for our patients. So you never underestimate the information that you give to your patients and the information you give to your communities that can save their lives. And with that, I would like to conclude. And if you have any question, please feel free to ask. Thank you so much.
Okay, thank you, Maha, for that great presentation. Now we're going to open the floor for questions. We invite our speakers to make sure you turn on your cameras and just join the participants to join us for a question and answer session and just a very brief discussion.
And I can start off with some questions in the question and answer. We have a couple of questions that were placed here. The first is the standard of care is clearly set and agreed upon. Does it differ according to severity of the case on admission? What are the determinants of severity? Is it level of consciousness? Are there different vital signs depending on severity, depending on whether they had a history of a prior stroke? We're asked to please elaborate. So do one of our panelists want to take this one first? So I think we often use the NIH stroke scale as kind of a starting point for global severity. The higher the number, the more severe the stroke is. Lisa, do you want to comment on how the plan of care changes for stroke in different circumstances?
Sure.
Different severities?
So one big delineation we have, is what's that appropriate level of care for the patient? And there's going to be a difference in the frequency of assessments and vital signs in an ICU environment versus out on our telemetry stroke units. So as Dr. Zing said, the NIH stroke scale score and that scoring based on severity of the score, the greater the severity of the symptoms, the more likely the patient may require to be in an ICU. Sometimes it's also dependent on the size of the stroke and the amount of swelling we can see in scans, because that can be a sign the patient is going to have greater deterioration, especially if it's greater than a third of the size of the MCA territory. We also sometimes can get concerned about strokes that are happen in the cerebellum because it's in a small little area near the brain stem, near the foramen magnum. You have a double fold of dura on top of that, and if there's any swelling in that area, the patient could herniate. So it is based on the clinical picture. When the patient shows up, are they protecting their airway? So do they need immediate critical care interventions? Do they need any of the drips that we can't do outside of the critical care environment? So it is taking numerous things into consideration to sort of decide the best level of care for the patient to be safe. But if either of my colleagues wish to add more.
I'm just checking to see if we have any more questions.
The second question about rehabilitation
Mhm.
is Maha, do you want to take this about rehabilitation? Expanding a little bit.
So what's the question exactly?
It says, well, it asks us why we haven't talked. It says, why don't you talk about rehabilitation? So a little bit broad. And
Okay,
please feel
so-
free to anyone if you'd like to put another question more specific in the chat. Sorry, go ahead.
So rehabilitation is an integral part of stroke care. Oftentimes the patient will come in an acute condition, and during the acute condition, if you didn't have a well-established stroke care, rehabilitation might go in the shadow, I would say. But it is really important to have initial functional screening to create a plan of care that is suitable for that patient, that is coordinated with multidisciplinary team. We know that earlier interventions of rehabilitation improve the patient outcomes, and delaying early interventions, early functional assessment, and early rehabilitation can increase the patient risk of disabilities, risk of aspiration pneumonia, risk of pressure injuries, and more complications to come. So the role of rehabilitation is a key. And if we are looking to a stroke care, rehabilitation is a large component of stroke care at all levels, whether in the acute level, even when the patient is still sick in the ICU, there are passive range of motion that we should do, head of the bed elevation that we should do. All of this is part of rehabilitation. And when I'm talking about rehabilitation, not necessarily we are meaning that the patient is actually physically engaged with the therapist in the gym. That would be ideal if the patient functional status allow intense rehab. But the basic functional screening is very important, and the follow-up for the patient outcomes with your modified ranking scale as well as FEM. It is really important for a care provider to follow up on these items and these parameters for their patients. So since this session aims to talk about prevention and risk factors and role of nurses, that doesn't dismiss the importance of rehabilitation and the role of our rehabilitation colleagues in improving our patient outcomes.
I just wanted to add briefly to what Maha said, and this touches on what Dr. Khoury had mentioned earlier. If you have a stroke coordinator in place in your center, and I know that a lot of hospitals do in the Middle East, there's certification there. AHA has certification. One of the requirements or one of the KPIs is to make sure that stroke patients are assessed for rehab. So I agree with you, Maha, 100%. I just wanted to add that in there.
Thanks.
Other
Thank you so
questions?
much.
Go ahead, Dr. Zing.
So which stroke scoring system is popularly followed in GCC?
Dr. Khoury, you're muted.
You mean the scales that we use? Stroke scoring system?
Yes. Yes, and I'm not familiar with the abbreviation GCC, and I apologize for that.
It means the Gulf. It means the Gulf
Oh,
region.
okay.
Yeah,
All right.
It means the Gulf region. So we use the same things everybody else uses. The NIH scale. We use the same things that are used everywhere. Typically, that question comes because the GCC has both American and UK type. So. But when it comes to stroke, my experience has been, and maybe Maha, you can add as well, is that it's been very American sided, not European. But unlike, for example, deliveries where it's very much a UK model with a midwife and all of that. There's other services where you feel like, oh, wait a minute, we've never done this in the US, but it's a very UK based type. But for stroke, it's very much a US based. So we use the same scales.
That's great.
Thank you.
Have any other questions?
Just to add to this point, And for the person who's asking about the scale, the NIH stroke scale is translated into Arabic, and the Arabic translation is validated. So if the care provider is an Arabic speaker and the patient is an Arabic speaker, they still can utilize the Arabic version of the NIH stroke scale to assess their patients, but still the same, basically 11 criteria.
Thank you. Well, thank you all for being with us today. It's truly been an informative session, and we appreciate your participation and engagement, and thank you for the great questions. I'd like to inform everyone that the evaluation form for the webinar will be sent to you within the next week, and there was another question about CME. And so once you've completed and submitted the form, you will receive your CME certificate.
Thank you.
Okay, thank you guys. Thanks for joining. Bye-bye.
And we did have one last, and we wanted to invite all of you to the 10th MENA Stroke Congress happening September 17th to the 19th in Cairo, Egypt. It's a major event. We'll bring together leading experts, researchers, and clinicians from across the region. So it will be a fantastic opportunity to network, exchange knowledge, and engage in insightful discussions. So we look forward to welcoming you in Cairo. Thank you.
Thank you. Thank you. Bye-bye.
Bye.